everyone. My name is Julia Mayetta. Hi everyone. My name is Julia Mayetta. We are so pleased that you all could join us for the 5th lecture of our lecture series. This 12-week didactic series brings you lectures from experts in the field covering different topics each week. The neuropsychology didactic series was created by early career neuropsychologists and trainees to provide free, high-quality didactic opportunities for the international neuropsychology community. We would like to go over the disclaimers for the series before we start. So this training is not meant to replace any formal education in neuropsychology, and the views of the speakers are their own and do not reflect the official endorsement of any institution or organization. Let's see. Make sure I go back to there we go. If you're having trouble joining using the audio, you might need to click the Join Audio button on the lower left of your screen, and please use the Q&A box to ask a question of the speaker. We will provide those questions to our speaker at the end of the lecture, and we will also provide a recording of this lecture in the next few days. Now it is my pleasure to introduce Dr. Veronica Bordas-Edgar for today's lecture on neurodevelopmental disabilities, risk factors in pregnancy and birth. Dr. Veronica Bordas-Edgar is an associate professor with joint faculty appointments in psychiatry and pediatrics at the University of Texas Southwestern Medical Center. She earned her doctorate from Arizona State University in 2008 after completing her predoctoral internship at the Boston Children's Hospital and Harvard Medical School. Dr. Bordas-Edgar went on to complete her postdoctoral fellowship at the University of Minnesota Medical School in 2010. She became board certified in clinical neuropsychology in 2014 and subspecialty certified in pediatric neuropsychology in 2019. Dr. Bordas-Edgar serves as a bilingual pediatric neuropsychologist at Children's Medical Center in Dallas and is co-director for this Division of Developmental Behavioral Pediatrics at the University of Texas Southwestern Medical Center. Her areas of interest include cultural and bilingual issues in assessment, genetic and neurodevelopmental disorders, and interdisciplinary teaching of medical and psychology trainees. For her service to the profession, she was awarded the 2018 Early Career Psychologist Service Award from the American Board of Professional Psychology. Dr. Bordas-Edgar is currently the president of the Hispanic Neuropsychological Association and on the board of directors for the American Board of Clinical Neuropsychology. So without further ado, thank you so much, Dr. Bordas-Edgar, for being here today.
Wonderful. Thank you. Really appreciate it. And I appreciate the committee for inviting me to speak with you guys. And so, you know, you guys have had a lot of really great didactics. And so I'm going to talk with you kind of about really from the very beginning, right? So the neurodevelopmental disabilities, thinking about risk factors that we see really with pregnancy and birth. And so, oops, you can go to the next one. I don't think it's going there yet. Let me see. Oh, there it is. Okay. So these are just our quick overview that we're going to do is looking at we're going to go a little bit quickly through cerebral development and that timeline, just because in terms of my organization, I like to think about when do these disorders kind of come on. So when are they at greatest risk? So that's why we're going to go through that timeline period. And then we're going to talk about specific issues that you might encounter more commonly in neuropsychological assessment. Okay. So most of the major congenital anomalies really occur by 10 weeks gestation. And so what that means is that really half of pregnancies and miscarriage, a lot of them actually unknown. So a lot of times it's prior to when someone identifies themselves as being pregnant. And so it's a much smaller percentage, it's only about 25% afterwards. During the first 3 months, though, it's about 80%. And half of those 80% are about due to an extra or missing chromosome, okay? In the US, congenital anomalies occur in about 3 to 4% of babies. Okay. That's letting me go. You can go to the next one. Okay, good. So here is just kind of thinking about what are the major events and peak times. So we're going to break down each of these as we go through. So we have neurulation in the first 3 to 4 weeks, and then prosencephalic development in those first 3 months. Then you have neuronal proliferation in those, again, 3 to 4 months, then migration, and then it's organized, and then we myelinate. Okay? You can go on. So in the first trimester, we have that early development of the neural tube and the major production of neurons. We have the basic axonal pathways of the brain system, and then early migration and early differentiation. So this is when we see kind of these first semester ultrasounds and screenings. And so already at this point, we're able to see right around 12 weeks when the sound screenings are done, some of these early congenital anomalies. Okay. All right, so what happens with neurulation? Oops, we can go back one. What, 2 more. Yep, here we go. Okay, there we go. So you can see where the, I'll just talk it through, but it's the slide right after this one. Okay, good. So we have the embryo, you have the endoderm, mesoderm, and ectoderm. And then you can see that this, I don't know if you can see my pointer or not, but the neuronal plate is going to form that ectoderm, and the grooves form at day 18. And then the tube begins forming at 22 to 24 days. And so all of this is really happening prior to most of the time when a woman knows that she's pregnant. Okay, then we have the anterior pore is going to close at about 24 to 26 days, and the posterior pore is going to close at 25 to 28 days. The rostral end of this posterior pore is going to become your cortex, and the caudal end is going to become the spinal cord. And so this is when we're going to see those early kind of problems with neurulation. So what do these disorders of neurulation look like? So here are a couple. We're not going to talk about all of these, but I want you to kind of be familiar. I think most people are familiar with anencephaly, which is really where you have a major portion of your brain and skull missing. And then encephalocele is where you have kind of the sac-like protrusion of brain and membrane, primarily through the skull. That cranioracheschisis totalis is really a combination of both anencephaly and bifida, which is going to be both your anterior pore closure and your posterior pore closure difficulties. And then kind of beyond that, myeloschisis is really a kind of a type of spina bifida, but it's a little bit more severe because you have your nerve tissue being fully bare, and then there's absent of this dermal covering or meningeal covering. With spina bifida, there's going to be different levels, and we're actually going to talk about this through a little bit more when we get to the specific disorders. But again, this is, and you have really 4 different types. I think it's maybe letting me go to the next slide. Okay, so then we move on. After you have your neuronal formation, you have your prosencephalic development. And so this is going to be the development of the forebrain primarily, right? And so there's 3 events. This is, you have formation, you have cleavage, and you have midline. And so what do each of these actually will be associated with different disorders. So if you think about prosencephalic formation, well, that's going to be more like your aprosencephaly or your atelencephaly, right? It's failure to form that forebrain. Cleavage, right? So if you're not cleaving, then you're having a single lobe, right? So that's your holoprosencephaly. So you're kind of alobar. It's most associated with like a sonic hedgehog mutation or trisomy 13. And then you can even have midline difficulties in early agenesis of the corpus callosum. We will also see that a little bit later on, but this is kind of maybe one of the first times where we might see that development of that agenesis. In the second trimester, we now have basic wiring of your brain, so really large connectivity. Okay, so thinking about this is the peak in neuronal proliferation. So at really 3 to 4 months, you have neurons about being created, about 250,000 new neurons per minute. So that's a lot of proliferation going on. And then at this point, you also are thinking about major connections to your thalamus, from the thalamus to the regions of your cortex. And so at this time, it's really going to resemble that adult pattern. You start to establish intercortical pathways, and again, more of the appearance of that corpus callosum. And then you have early apoptosis. You also are going to begin to see your first motor activity of the fetus right about 18 weeks. Is generally about when mom can feel it, and then other people kind of can feel it outside of the belly right around 20 weeks. Okay, so what can go wrong in the second trimester? So disorders of proliferation. So thinking now, we're supposed to be making all of these new neurons, and if we're not making a lot of these new neurons, then we tend to have what? A smaller brain, right? So microcephaly, that's generally what we see with this disorder of proliferation. It can be familial or genetic, but it can also be due to some teratogenic effects. So most commonly, you're going to talk about radiation, so that can be avoidable, hopefully. Any kind of metabolic toxins. So we'll talk about fetal alcohol syndrome a little bit more towards the end. PKU, this is preventable if we are catching it early. You can actually prevent some of the more severe developmental disabilities and intellectual disability associated with PKU. But still with treated PKU, we still might see some kids having learning difficulties and attention difficulties. And then the other being infections, so maternal infections, torch infections, CMV, rubella, and we'll talk about these in a little bit. The next area that we're going to think about is, okay, so now we've made all the neurons, and now the neurons have to go somewhere, so that's migration, right? And so if we have problems with the neurons getting to the right places, then our brain is actually going to look different, right? So you might have schizencephaly, where the brain might look a little bit more porous areas, and some it's the development of how the brain's appearance looks very different. Lissencephaly, you guys might be familiar with that. So this is where we kind of think about smooth brain, so we're not seeing a lot of ridges. But you also might have pachygyria or polymicrogyria. And so where you're seeing, again, either increased grooves or just smaller grooves, and they're just not, again, being formed correctly. A lot of these, especially lissencephaly and schizencephaly, could be associated with seizures, but most of these are going to be associated with your developmental delays, intellectual disabilities, sometimes motor issues as well. And then you're going to also, here again pops up your agenesis of the corpus callosum, right? Because if they're not migrating there, we're not forming that correctly. And then also you might see some cerebral cortical dysplasias. Then disorders of organization. So we've made the neurons, we've gotten there, and primarily, again, this is not exclusive to this, but you're thinking about how are neurons, how are connections being organized. And so these are some of the main early ones that we would think about in terms of how those neurons are being organized, in terms of how they're connecting and how they're synapsing with other neurons. So again, you can see these are primarily genetic issues, right? Down syndrome, Fragile X, Angelman's, autism and intellectual disability. Some of these can be secondary to some of the other early problems that we've just talked about. Okay, so that brings us to the third trimester. We're almost there. Now we have your large descending pathways, kind of this top-down connectivity from these sensory to motor systems. Now we're having reciprocal connectivity from these higher order cortical areas to your primary areas, and then early myelination. All right, so what are some disorders that can happen here? Oh, sorry. So by birth, most, your neurons are generated, your incoming major sensory pathways are there. You're kind of going through some early refinement. And your microstructure of a lot of the features such as motion, orientation, the visual system are present. And again, there's major cortical pathways are there. So this is when we have early newborn screenings. If you guys have heard about Apgar scores, if so, those of you who work with pediatrics, these are what the Apgar scores are based off of. And so this is why it's important for us to ask. So they range from 0 to 10. They're generally taken at 1 minute, 5 minutes, and 10 minutes only if needed. If they're really low at 1 and 5, then they'll take them again at 10. But generally, they might not even take them at 5 minutes, but they'll always take them at 1 minute. So you can see, 7 to 10 is normal. I love it sometimes when parents are like, oh, they had perfect scores. I'm like, okay, I mean, that's great, but it doesn't really mean a whole lot that they had perfect scores. Generally, yes, we want them to have these excellent scores, but you can still have, be in excellent condition and maybe had a little bit of, kind of low pulse or kind of a little bit of kind of blue extremities. Okay. So those are some of the more the more common ones that you might see. So that's just a kind of a good reference for you guys. Okay. So again, with third trimester and post-birth, so what might we see are disorders of myelination. So primary disorders of myelination, thinking about kind of those cerebral white matter hypoplasias. We also might think about kind of inborn errors of metabolism, like the leukodystrophies. So these are kind of amino and organic acidopathies. We might also see some congenital hypothyroidism, sequela of periventricular leukomalacia, which we'll talk about here in a little bit, due to prematurity. And then, of course, anoxic ischemic encephalopathy that we're going to see pretty early on in the newborn period. And then again, you might have other postnatal insults, other people, these are not all the disorders, because of course, later in life, we're going to have some other disorders of myelination that we might see, like MS or something like that. Okay, so again, going back to this developmental timeline, some people are verbal, some people are visual. If you like more of a visual timeline, this one's for you. So I like to kind of include that in there. So you can kind of see all of these things it's not just one thing happening at a time. You have multiple processes happening all at once. So, and then of course, myelination is going to continue on into adolescence. And you have synaptogenesis and then pruning really happening. You really have all of your synapses formed by about age 6, and then those get pruned back into about the normal levels or adult levels by age 14. Okay. So now let's talk about these disorders. And we're, again, talking about them in order when we see them. So your neural tube disorders, thinking about spina bifida, this is going to be one of the most common ones that you're going to see in pediatric neuropsychology. So you do have your upper neural tube defects, right, which we talked about, anencephaly. Dandy Walker is also one of these. And even Chiari malformations would be an upper neural tube defect. But then spina bifida is really a lower neural tube defect, okay? So thinking about that spinal cord, this will generally occur in 25 and 28 days gestation. So again, oftentimes before a mom knows that she's pregnant, and causing at least one or more of the vertebra to form properly. This is actually the most common neural tube defect. There has been a decline in the incidence rate. It's thought to be likely due to additional folate supplementation, but really that's not the only cause. So even if you had good prenatal and you were taking enough folic acid, there's still thought to be a risk for this, and it's because of this genes plus environment factor. So it's not just lack of folate supplementation, but I will say there is still a slightly higher incidence in Latinos and Hispanic populations, But hopefully we're seeing that decrease. Actually, the FDA, kind of started out with supplementation of kind of other grains and white breads a while ago, and it wasn't actually now it'll be about 2 years this fall when they started supplementing other foods, including ingredients for making tortillas and those sorts of things. Okay, so what are the forms of spina bifida? So you have spina bifida occulta, which you necessarily wouldn't see, doesn't always come with a lot of neurocognitive issues, but spina bifida cystica, we will see it with meningocele and myelomeningocele. And so you can kind of see the two pictures here of meningocele versus and so your myelomeningocele is going to include both spinal cord and meninges that protrude outside of the body, and then meningocele is usually in kind of lumbosacral region. Has a slight risk for hydrocephalus. Myelomeningocele is going to have a higher risk for spina bifida, and I'm going to show you on the next couple slides kind of your risk factors. But so there's a lot of neurocognitive effects, right? So there's a lot of other medical associated factors with spina bifida, but this is kind of what we consider this biopsychosocial spectrum. So executive functioning is going to be a major area that we're going to see difficulty. So even if a kiddo is doing pretty well cognitively, that's going to range. A lot of it's depending on their kind of what level in the spine their spina bifida was, the level of hydrocephalus, the level of repairs that they need. And so that's going to also impact their adaptive skills. But executive functioning primarily in the areas of problem solving and organization, attention, and then early learning and memory, especially in those adolescents, that's going to be more prevalent. We might also see difficulties with language. So, pragmatics, early language, so kind of this phonological awareness, syntax, vocabulary. And then it's really common to see difficulties with mood and temperament, specifically anxiety and depression, especially in our adolescents. And then, of course, there's going to be difficulties with social skills, family dynamics. And in terms of, so what does this look like with the hydrocephalus? So with myelomeningocele, it can start off at the T level all the way to sacral level. And so if you think about thoracic for all the way to lumbar level number 2, that's going to be about 90% of those kids are going to have hydrocephalus. So the higher up that it is on your spine, the greater chance of hydrocephalus. But even with sacral lesions, it's still going to be about 60%. Most of these kids are going to have shunts placed shortly after birth. But as we know, a lot of complications that we can have with shunts. And so with these malfunctions, with shunts, we're going to see increased irritability, decreased consciousness, loss of milestones, a lot of headache pain. So those would be, gait issues, vision problems. Those would be things that you'd want to kind of cue you into that. The revision rates are going to be variable. Generally, if you're going to have a revision, it's going to be in those first 2 years. But, a lot of kids, we might see 60% even at 5 years, and it's really 80% at 10 years. Of course, we know that greater shunting and greater hydrocephalus is going to be associated with more white matter damage. So again, more difficulties with memory and learning and executive functioning. Okay. So that moves us along to maternal illness. So thinking about the torch disorders. So this is one of those kind of ABAP type things you just got to memorize. So what does torch stand for? So toxoplasmosis, which we'll talk about here. Other agents, I don't know why they put that there. So rubella, cytomegalovirus, and herpes. Okay, so cytomegalovirus, or CMV, is actually the most common congenital infection. And so microencephaly, this is the best predictor of outcome. If you don't have microencephaly, then you might do better. These kids tend to have hearing loss. Again, if we're thinking about this, usually we'll see this during that second trimester. That's when some of those hearing and sensory pathways are being formed. So that's same thing with the visual. So this is why we will see those, because those are coming on in that second trimester, right? So hearing loss and visual processing or visual impairment. These kids are at greater risk for infection, for intellectual disability, motor difficulties, ADHD, and even autism symptoms. The earlier, again, and with all of these that we're going to talk about, especially with maternal illness, the earlier that mom is exposed to these illnesses, the more symptoms you're, right? So if the mom is contracting CMV or any of these torts disorders in that second trimester, again, this should be kind of in your your cheat sheet, right? You're going to probably have hearing loss and visual issues, so some kind of sensory stuff because of that. That's when those pathways are being formed. And then the later, so if they're not contracting it into that later third trimester, then it's going to be, we've already established some of those early pathways. So it's likely going to be more frontal and some of those higher order things. So you may not see intellectual disability in that kids with CMV in the third trimester, but you might see a lot more ADHD and behavioral dysregulation. Okay, so herpes. So this is, again, you can kind of see where I'm going with this. So cognitive, intellectual issues, difficulties with our kind of early language development, may have more language delays, language disorders later on, symptoms of autism, problems with attention. Longitudinally, we might see difficulties with kind of that lower performance or PIQ, difficulties with that fine motor. And then as adults, we might see more problems with memory. Toxoplasmosis. So some people are familiar with this. This is actually cats. So if you have cats around you in pregnancy, this is a common risk factor because cats transmit toxoplasmosis. And so if you get it in that second trimester, that's when you're going to have worse outcomes. But even so, this is going to be associated with increased risk for seizures, intellectual disability, again, that hydrocephalus and motor difficulties. Rubella has very specific target on cranial nerve 8, so that vestibular cochlear nerve injury. And so again, you're going to see kind of more auditory difficulties in kids who get rubella or through mom gets rubella during pregnancy. You're going to have more hearing difficulties and pretty extensive. So they could have pretty extensive, profound sensory neural hearing loss, and then deafness is common. These kids will also could have higher risk for autism, and then intellectual disability and cardiovascular difficulties. Okay. All right. So varicella or chickenpox. If this is, again, another one where we got to think about timing. So early in pregnancy, you might have fetal death. But these kids actually, one study found that some of these kids actually had less behavioral problems than they did it with, later in pregnancy. And it may have been because they had some other neurocognitive issues. But if we contract it in later pregnancy or right around the time of birth, we could actually see some, so cortical atrophy and then also intellectual disability. With HIV, again, I know all these, you just don't want to get sick when you're pregnant, because I'm like saying the same things over and over. HIV, developmental delays, intellectual disability, could be common, but again, there's going to be a spectrum there. And it's going to be due to the timing of transmission. If you're transmitted in utero or during the birthing process. So during the birthing process, we may actually not see intellectual disability or developmental delays, but we might still see some of these other difficulties. So with attention and executive functioning, specifically thinking about problem solving, kind of that cognitive flexibility, sustained attention, vigilance, and processing speed. And then also for even if you later or during the birthing process, so memory, language, motor skill difficulties. Okay. The other issue with prenatal exposure are those were illnesses, maternal illnesses, and now we're kind of move into kind of prenatal exposure. These can happen at any time, and so we talked about some of these teratogenic effects that we're going to see primarily with proliferation, right? Microcephaly. Remember we talked about that, and so multiple chemicals and drugs are going to have these teratogenic effects. Again, you're going to see a range. All the way from death, physical disabilities, developmental disabilities, and some of these kids actually may have more subtle neurocognitive outcomes that we're going to talk about. Although we would never advocate for any of these things or say these things are okay. But yes, so some kids we might see some more subtle difficulties. Right when babies are born, they might be diagnosed with what we call neonatal abstinence syndrome, and so there's a big uptick in folks investigating this, especially with this increase in kind of the opioid usage in parents or in moms. And so, but really this is where kind of this period of withdrawal when newborns are having, they're kind of born addicted to drugs, and then kind of this weaning off and withdrawal period. And so we might, they might also, you might also start seeing that a child had early neonatal abstinence syndrome. Okay, so what might this look like? So let's talk about cocaine first. So with cocaine, we're going to see low birth weight prematurity, which has its own effects. We're going to talk about that in a second. So microcephaly. And so with that, that's going to have impact your cognitive processing. A lot of these kids have language delays. And again, just like you heard a lot of ID with those maternal disorders, with these prenatal exposures, you're going to hear about executive functioning and behavior. So again, when you're classifying, when you're kind of trying to think about how do I organize some of these disorders, these are some, good key points to hang your hat on. Okay, so again, academic difficulties. If you look at this, kind of how your brain lights up, that normal brain, and then it takes a while. So even at 100 days, these are infant brains, you guys. At 100 days, that infant brain is still not firing like that normal brain born at term is. And so, it's a long period of withdrawal that these babies are going through. The second one is going to be narcotics, so opioids. Some of these things are going to be much more common right now. So morphine, codeine, heroin is made from morphine, and so heroin is part of these narcotics opioids category. Again, sounds familiar, right? Problems with these babies are going to be born often premature, going to be very small, so that low birth weight. We're going to see those executive difficulties. These kids also, though, we're going to see more spatial learning and memory problems. With heroin specifically, you're also going to see visual motor deficits. And, there's this last point here is that a lot of times, sometimes kids will remain with that parent if a parent can, hopefully can get clean, but some of these kids are still going to have more difficulties with cognitive processing, reading, and math. All right, so meth. The problem with meth is that it is really receptive in the body, and it actually stays in there for a longer period of time. Okay, so once it binds in there, because meth resembles neurotransmitters. And so when a baby is born, because it's tricked that brain that this meth is a neurotransmitter, these babies' brains actually look like asphyxiated infants. Okay, so just thinking about that. So we are going to see, again, the executive functioning and behavior difficulties, but we're also going to see anxiety and depression, ADHD. We're going to see, oopsies, forward to, also poor visual motor integration, verbal memory, long-term retrieval, and spatial memory. Okay. And so, yeah, so this is one of them, more dangerous ones. And meth use is only second to marijuana use. So marijuana is still the most common prenatal exposure. Well, of tobacco, but in terms of these drugs, we actually know less about it. But we still, can think about the attention and emotional dysregulation, the visual spatial deficits, and actually what we see in really young kids that have been exposed to marijuana in utero, we might see kind of this ADHD depressive symptoms in that school age period. So before 10, these kids will often have really severe behavioral problems and delinquency. So kind of more conduct, antisocial problems in adolescence. The difference between marijuana and some of the other drugs is that we actually, with marijuana use in moms, these babies don't tend to be born premature or low birth weight, so we don't tend to have those secondary difficulties, and there's no clear evidence that these babies have neonatal abstinence syndrome, but we do see that with all of the other drugs that we've talked about. So tobacco is also one of the more common, parents, this is an easy one to ask parents about. And I always recommend asking about, any kind of drug use, any kind of, even medications that parents took, because remember we just talked about opioids, but any other medications that they took, any smoking. And parents have no problem telling you about smoking. They might have a little bit of a problem telling you about alcohol, which we'll get to that in a second. That's next. But in terms of tobacco use, parents are pretty open about this one. And what we don't realize is actually there's a 3-time risk factor of having ADHD. So this is really the biggest risk factor for tobacco use in pregnancy. And so, so smaller head circumference. They might also have lower birth weight at birth, but actually that lower birth, that smaller birth or weight actually persists even at 3 and 6 month old checkups. So we still might see smaller babies. So some of that's at nerve. So sometimes, if parents are smoking, that also has kind of a decreased, kind of more like satiation factor. Externalizing behavior problems in addition to ADHD. And then these kids will often see difficulties with math and spelling. And they might have later obesity and also undernourishment. So both, so even if you're obese, you can still be undernourished in terms of the proper nutrients. So we'll often see that later on in those school age kids. Okay, we're gonna spend some time talking about alcohol. The only way to have fetal alcohol syndrome is to be exposed to alcohol in pregnancy. That's the only way, and it's preventable. So, but this, for all these, has the most serious and long-lasting effects. Okay, it is still the most common teratogen. So estimates really range. So the thoughts are that it's about 2,000 children born each year that are born exposed to alcohol, but the range is really, which is about almost 2 per 1,000 births. However, some of the estimates, because parents are really unwilling, or sometimes, whoever takes the child is just unsure, the documentation is not there, but there's really thought that this could be upwards to 2 to 5% of kids per year. All right, so questions we always get. Type of alcohol does not make a difference, whether it's a beer, whether it's wine, doesn't make a difference. It still has effects. There is no safe amount. There are studies that kind of, think about amounts, but, look around you, right? Ask your friends. One drink, whatever that is, whether that's wine, whether that's beer, or something else, it's going to affect you differently than it affects another person. So how you metabolize is going to be different. And so because we're not able to really predict that metabolism and secondary kind of how that then gets transmitted into the placenta, we really don't have a good, clear sense of the safe amount. So some, and for neuropsychologists, this may be shocking, and it may not be, but the kind of gynecologists will still, promote like, well, 1 or 2 every now and then is not that bad. What I tell my friends, because usually, when I see patients, they've already had the kid. But my friends, I'm like, well, yeah, 1 to 2, but you don't ever know if that 1 or 2 is going to have a bigger effect on your particular kid than it might be on somebody else. So there really is no safe amount. Okay. So how does it work in the brain? So alcohol actually suppresses glutamate and enhances here we go. Other releases. And so these neurons are going to receive less excitation and neurotrophins, right, than they normally would. These neurotrophins, if you're not receiving those, right, you're not getting this, then that's going to result in apoptosis. And so, right, or the cells to begin to die. And so in addition to that, you're also going to see dendrites that are shorter. They have fewer branches, so you're not making as many of those connections. And so then what does that look like in the brain? So here is a normal brain of a baby at 6 weeks. And here is the brain of a baby that same age that had fetal alcohol syndrome, okay? Our estimates are going to, vary, but it's thought to be that these babies have, their brains are about 13% smaller. You're going to have fewer gyri and sulci. Again, you can see the atrophy right there. You're also going to have underdeveloped areas, especially that corpus callosum. Okay, so we talked about it's not always super easy to get a good picture of alcohol in use in pregnancy. And so it's just important to ask everybody. When I train residents, I tell them, you just got to get comfortable asking every single parent at, especially at those newborn well checks. And so, and then once you get comfortable asking every single parent, it just comes natural. And so it comes off less judgy. And so you're not like, oh, I'm going to try to catch you in this, but you're really, trying to figure it out. And so, again, this is the, it's really an fetal alcohol spectrum disorder, right? So there's not just one type. And so full fetal alcohol syndrome, you're going to have all of these presence of the facial anomalies, CNS defects, growth impairment. You could have partial FAS, but most commonly what we're going to see actually is, we're still going to see FAS if it's been confirmed, but we're also going to see alcohol-related neurodevelopmental disorder. And I'm going to show you why, and then also alcohol-related birth defects. Why you might not see that full FAS here, because to have a full medical diagnosis of FAS, you have to have all 3 facial anomalies present. For partial, you only need 2. But for the alcohol-related neurodevelopmental difficulty or disorder, you don't have to have that. So why is that important? Because we're going to go back to that cerebral development timeline. In that first trimester, that's when those facial part being formed. And so if you did not have alcohol exposure in that first trimester, or the heavy alcohol exposure was not in that first trimester, you're likely not going to have the facial aspects or the facial abnormalities of FAS, okay? Doesn't mean you don't have FAS or we're not exposed to heavy alcohol usage, but you're not going to have those generally be present, okay? Most people don't, just all of a sudden start with the heavy alcohol usage, but so that is a way that, if there has been suspected, so you do have to have, confirmed prenatal alcohol exposure, right? And that can be, someone's family member said, no, I've seen them drinking, while they were pregnant. But generally you're going to have some sort of, all of these are going to have at least 3 domains of CNS impaired, right? So whether that's going to be language or memory or motor. Okay, so what does this look like? So generally lower IQ. Again, there's going to be a range here, but generally lower IQ. You could have, intellectual disability. Memory is a common impairment. Of course, executive and attention problems, but really severe on behavioral regulation. So especially kids who are less FAS, but more on the spectrum, that emotional behavioral regulation is going to be a really common referral question, and even into adolescence. And so, but also the academics, academic difficulty. So reading, spelling, math, and then again, even adaptive functioning, we're going to see problems with adaptive functioning. Even if they don't have ID, we're generally going to see some of that. But again, if you're hearing a lot of behavioral and emotional dysregulation that really seems to kind of not fit, and it can be pretty severe dysregulation, then that's going to fit more that picture of the FAS. So even if they're having more of a kind of IQ in those kind of 80s, low 90s, you're still going to see that. Okay, so we've made it to birth, but now we're born a little bit early. So this is kind of that, we've gotten through. These low birth weight, prematurity can be associated, as we just heard, with a bunch of other things. But so thinking about gestational age, so we have preterm, very preterm, and extremely preterm. So it's important to ask about how many weeks, because some parents will still tell you, oh, they're born full term, they're 36 weeks. There's still going to be some risk factors there, so you really still want to try to capture that if you can. And then extremely preterm is going to be less than 28 weeks. And so birth weight is also important to capture, because you could also be low birth weight for your gestational age. And so and the combination of that is really important in terms of kind of higher risk factors. So they go by grams, and so, but I've given you a cheat sheet there because most parents don't remember how many grams they were, but they'll tell you how many pounds they were. And so this is a good way to kind of remember that. Okay. So time inside the womb is very, very important. So here you have a preterm baby at 31 weeks. Compare that brain to a full-term baby at 40 weeks, right? You're going to see, look at how, kind of the lighting up of areas, looking at kind of those grooves and that development, and even, so comparing that to the term baby. So that same baby at 40 weeks is still not looking as nice as this term baby. So even though they were in there, so we're still adjusting or having that corrected age for up to 2 years, but it's still not catching up in the way that we would like it to, generally. Okay, so what are some complications? This is why it's important to ask about how many weeks. So respiratory distress, which we'll talk about here in a second, is common, and it's even common for those late preterms. So increased risk for infection, what we call PDA. So if you hear PDA, that's patent ductus arteriosus. This is where the one of the kind of the major vessels in the heart is not fully closed. You might have, and actually PDA can self-resolve, and if it's not, it doesn't self-resolve in the hospital course, then they will fix it. But generally they'll try to help see if it self-resolves during their NICU course. Necrotizing enterocolitis can also be a problem. We also are going to see hypoxia, ischemia, especially when parents have preeclampsia or abruption. So preeclampsia, so this is caused by high blood pressure. So we have to ask, did you, if they were on, blood pressure medicine, were they monitoring for for high blood pressure? And then did they go into that preeclampsia, and then placental abruption. Those things might cause more hypoxia or ischemia during the birthing process. Kids might also have IVH, or so intraventricular hemorrhage, and that can lead both to periventricular hemorrhagic infarction or PVL, which we talked about, which I'll give you some examples of here. Okay. So very preterm, very low birth weight. You're going to probably see more deficits in executive functioning. Attention is in bold because that's going to be really prominent. Learning difficulties, again, behavioral stuff. But the developmental course is going to be variable. So you might still have some declines in cognitive and academic functioning. You might have some lower self-esteem. But there's going to be a variable course. Extreme prematurity, you might see, again, those vision hearing problems. All preterm kids generally going to have this restless, impulsive, inattentive. And so why is this important? So in early childhood, especially those very preterm, those are the kids that are going to get identified, right, in these these follow-up clinics. So they're going to have more cognitive, more motor difficulties. So, cerebral palsy, language and speech. But even if not, you're still going to see in mid-childhood and adolescence, even for some of those other kids, you're going to see visual, motor, memory, executive functioning problems. So it's really common for kids to be doing really well. They get dismissed from these early childhood or kind of these follow-up clinics. And guess what? When they're 6, 7, 8 years old, they're coming back. The parents are like, I think they have ADHD. I'm like, this is kind of a late effect of prematurity. And so now we're kind of linking those things. So the referral question is often going to look like an ADHD or learning difficulties. For those late prematurity, or just kids that have, even if they did really well, we might still see that. And then anxiety is going to be another common factor that we might see in school age and adolescence for kids that were preterm. Okay, so IVH, we go by grades. And so, but these are often seen within days after birth. And so grade 1, you're going to have kind of small bleeds. Grades 2 and 3, they're going to be when you have bleeds inside, so within the ventricles. Grade 2 is less than 50% of the ventricles being full of blood, and grade 3 is greater than 50% of ventricles being full of blood. And then grade 4 is when you have it both within and external to the ventricular system, and so that's really more of a periventricular infarction. Lower grade can be relatively benign. Again, higher grade, you're going to see more motor and cognitive impairment. And so PVL is another major effect. Again, primarily you're going to see it in very preterm and extremely preterm. In term babies, you might see it, but they generally have kind of that low birth weight. That's what we talked about that. And so the early hemorrhage, you're going to see within days. Leukomalacia, this is that white matter, right? So we call it's a problem with myelination. You're going to see that weeks postnatally. So you're generally not going to see it at the very beginning. You can also see it with respiratory disease, which we'll talk about here next. So 2 types of PVL. So you might have cystic PVL, which is going to have more frontal, parietal, occipital difficulties, so often associated with cerebral palsy. That's why it's cystic. And then milder PVL, you could have maybe more of just a kind of signal abnormality on MRI. developmental coordination disorders, CP, are going to be really common. You might be at greater risk for seizures, visual difficulties, cognitive, executive functioning. Again, thinking about that frontal striatal problems and nonverbal learning disability. You might also be at increased risk because these kids might have, because of that kind of that nonverbal learning disability and some of these other kind of motor and difficulties. Some of these kids, there's kind of an increased risk for autism or autism diagnosis. It's not always autism though, and so you have to really look closely. Some researchers in autism will say, oh, well, if you're born preterm, you're likely to have a greater chance for autism, which is true. But you really want to differentiate what that PVL looks like compared to kind of your typical autism. Because it's sometimes there's an overlap in symptoms, but they're really two different things. So again, with PVL, because you're having decreased myelination, you also might have actually decreased cerebellar volumes and corpus callosum and ventriculomegaly. All right, so respiratory distress. So we talked about, again, most of these cases are premature. You can have some full-term babies that are going to have respiratory distress. And why that happens is because you have a deficiency in surfactant. So surfactant is kind of that sticky substance in the lungs. And so it keeps the lungs, because it's sticky, from popping open and having that nice breathing. And so there's some risk factors like diabetes. So again, this is why you want to take that good history. Actually being induced or having a cesarean could be a potential risk factor. Again, because they're not having, when a baby kind of is born kind of vaginally, you're having more of that squeezing, and then when they're born, they're having a little bit more of like that oomph. And so that could be kind of that heightened risk factor because you're kind of getting it out during the delivery process. But problems in delivery, reduced blood flow, having multiple births, so twin birth, for example, is a heightened risk factor, and even rapid labor, because again, you're not having that same effect that the baby's going through. If you have respiratory distress, you're at heightened risk for bronchopulmonary dysplasia. And so you can also look in the chart in terms of kind of low oxygen sats. So if they're below 90, that's going to be hypoxemia. Below 80, you might actually start to have kind of increased problems with brain and heart functioning. Okay, last section is neonatal encephalopathy. So just talked about hypoxemia. So what can happen? You can have a hypoxic ischemic event. Often this happens perinatally. Perinatally is really could be during birth up until about 28 days post. One of these, it's actually one of the leading causes of infant death. And so again, it's that difficulty with respiration. Babies have kind of poor tone, poor reflexes, subnormal consciousness, and seizures. Okay, causes are going to be, again, placental insufficiency or abruption, more of a prolonged labor, or hypotension. And so how we judge how severe the hypoxic ischemic event is, it's going to be on SARNAT staging. And so really, I just kind of put this in there for your reference to know. But if you have more severe encephalopathy, so you're at higher risk for death and disability. Again, CP, epilepsy, deafness, intellectual disability. And then even with moderate, you're at about 25 to 50% risk of having problems with some of these more milder things. So again, milder memory, visual perception or visual motor difficulties, hyperactivity, learning problems. And these problems, even for kids who are more milder, might persist into adolescence. So verbal and visual recall, executive functioning, and speed. I think, and then you're going to have you could have 2 phases of injury. So at the time of insult, and then this later after you have resuscitation and oxygen. And then you can also have, secondary problems with seizures. Cooling treatments have been used, but it's really better for moderate or mild HIE and not as accurate for severe HIE. But it does help to block that neurotransmitter release, which causes the apoptosis. So now I think we can, I just put on here some resources for you guys. Certainly there's some neuropsych books, but actually, some of these websites you can give to parents. Treatableid.org is one where, I give this a lot to residents to think about what are some treatable causes or illnesses that might cause intellectual disability. It's kind of cool to kind of go on there, and you can look at different signs and symptoms, play around on there. Healthychildren.org. This is from the American Academy of Pediatrics, and it's really geared towards families, so it's a good resource for them. And then, of course, OMIM is another one. That one, and rarediseases.gov are two that you guys can use for your own resources as well. So I think we're ready to open it up to questions.
Awesome. Thank you so much, Dr. Bordes-Edgar. That was a wonderful presentation. We did get a few questions, so we'll just start off with the first one was about the beginning of the presentation. So can any of these prenatal malformations self-correct? For instance, if developing spina bifida, but then properly supplemented, is it possible for it to resolve?
No, so spina bifida would not resolve on its own because you've already then created the inability for that neural tube to close properly. I should have said, actually, there is surgical correction that is done prenatal, or not prenatally, but perinatally. So while a mom is still pregnant, there's surgical correction that can be done. Generally, there's going to be risk factors, of course, with that. But and correct for that, and that can actually help with some of the later motor difficulties that kids might have. And so it'll help with that development. So supplementation wouldn't necessarily do it, but the surgery can. The risk of that surgery is prematurity. So,
okay.
So we're, while we're still we're managing some of the more severe effects of spina bifida by doing that prenatal surgery, we're still having some of the other risks, and so then the compounding things that we would see with prematurity and low birth weight.
Yeah. Okay. The next question is about specific populations that may be at higher risk for these disorders. For example, is there an increased risk associated with IVF or other procedures? So if IVF rates increase, will we likely see an increase in any of these disorders?
That is a great question, and I do not know the answer to that. I would have to look that up. Okay. But that's a really good question. I would have to research that a little bit more. Yeah. Okay. Generally these moms are being supplemented with more, vitamins and transmitters kind of earlier on. So there is a higher risk for these kids being kind of having spontaneous miscarriage, but not necessarily anything that I know of specifically for some of these other things. I think anecdotally what we've seen is, again, more on the ADHD side, but that could also just be an effect of working in a developmental disabilities clinic. So.
Okay. So next question is about medication and or drug use. So for mothers who use Adderall, for example, therapeutically for ADHD, is it recommended to taper off during pregnancy?
For the mom to not have that? Yeah. So yes. but working with their physician is what I would say. So, because it really depends on if you're thinking about ADHD meds, that's going to be different because not everybody that has, it's really only about 25% of kids with childhood ADHD are going to continue with adult ADHD, and a small portion of those are going to have still going to be taking medications in adulthood. And so, it's kind of like, what's the purpose that you're taking, those ADHD meds in adulthood, right? If it's going to be to helping you focus, and we're going to have more driving accidents, then we wouldn't want to do that. So I think it's going to be in conjunction with mom's physician. But generally, yeah, they will change the medications that have lower placental entry. So even if you're thinking about anxiolytics, antidepressants, those sorts of things, they will work with you on decreasing those. Often, even in especially in individuals with bipolar disorder, taking lithium, those sorts of things, they will try to either remove medications during pregnancy and just really closely monitor those moms. Mm-hmm. So if that's a concern, definitely one should bring that up.
Somewhat relatedly, do you have any recommendations about increasing the likelihood that parents will self-report use of either medications or substances during pregnancy in history taking?
Yeah, absolutely. So just, you want to practice feeling comfortable. If parents are like, oh, you ask everybody this, if you ask, like, did you, right? A did you question, parents are like, oh, why are you asking me, did you? So we just say, you can say how much, how much did you drink during pregnancy, right? So that takes away the judgment, assuming that they probably did. If they say, oh, I didn't drink anything, okay, fine, because they'll tell you if they didn't. And so, but if you say, like, how much, oh, then that opens the door to, I'm okay with whatever you're going to answer me. And so I generally will start with tobacco and alcohol, and then I'll do and then I'll just say, what about any medication? So instead of having to say, how many drugs did you take, right? Because you've already asked them, like, how much alcohol, how much alcohol did you drink during pregnancy, something like that. And then I'll say, well, what about any drugs or any prescription medications? And so you don't have to then go back to say how much or did you, but it's just like, well, what about this? And so that generally helps parents to kind of feel comfortable. And if they give you a weird look, just say, I ask everybody these same questions. It just helps with my documentation.
The next question was related to when you have kind of a speculative history. So in cases where children may be adopted and you don't know a lot about the birth mother, for example, what would you do in that situation where you suspect maybe there was some prenatal exposure?
Great question. It depends, because I do see a lot of kids in foster care and who have been adopted. So this comes up a lot. So generally, they'll, you kind of want to assess, like, is it that someone's like, well, I think so, or like, I have a high suspicion of it. So you want to really determine what that is. You still probably wouldn't call it, you're still not going to call it FAS, but you're going to say, you could say probable. And so oftentimes I'll say probable not neurocognitive, but probable exposure in utero, or there's high concerns. So you would document that in your background section, and then you really want to look at, can you hang your hat on, if you're looking at their neurocognitive profile, is there anything else that's possible that it could be related to? And if not, then, that could be it. Now, oftentimes there could be, this kind of other psychosocial, difficulties with moving from house to house and different placements and those kinds of things. And so it's really not going to necessarily be one thing, but it could be a combination of all of these things. And you can just put all of that in your impressions.
Okay. Next question is, are there any rehabilitative approaches for neurodevelopmental disorders if there are always cognitive disabilities?
Yeah. So, So similar to, what you would do with your, typical ADHD, right? So a lot of these, similar medications and treatments are going to still work. So if you're thinking even about like habilitation or adaptive functioning supports, neurocognitive type rehabs, even some of the medications that we would prescribe for ADHD and behavioral difficulties are really effective. Even though the cause is different, because we're still seeing the same symptoms, the treatments are really focused on the symptoms, not necessarily the cause. So they can actually still be pretty effective.
Okay.
And again, you would still recommend, your typical speech, OT, PT, those sorts of things as well.
Okay.
And behavioral therapies. Now, I will say behavioral therapies may not be as helpful depending on how severe it is. And so you're going to you could do a combination of medication plus behavioral, and then working really closely with families.
Let's see, a couple more questions. We got a lot just in the last couple of minutes, so I'm going to get to as many as we can.
Okay.
What about the effects of, or father's effects on prenatal and neurodevelopmental disabilities? Is there any evidence for that?
That is a great question, and I don't have a good answer for that. I don't know, because that's not something that I've really looked at. It would be more of a, like, if we're thinking about stressors during pregnancy and maternal stress, as opposed to, and then of course genetics, but not necessarily in terms of, you could think maybe secondhand smoke or those kind of things, but not, I don't know of any good research or thinking that's come out otherwise in terms of paternal impact on pregnancy. So positive or negative, really. I think it's really more through that maternal stress, avenue.
Gotcha. We did get one question about maternal stress, so I'm not sure if you want to say anything additional about that. And we also got a question about breastfeeding influences.
Ooh, these are great questions. So maternal stress, yes. I can briefly say, again, it's like everything else. So if you think, it's kind of dose dependent, if you will. And so a little bit of stress is, because, most moms are stressed, right? And if you have more kids, you're going to be more stressed. But that common stress is not really the kind of maternal stress that we're talking about. We're talking about really more extreme stressors. So, worrying about, home living environment, possible abuse, possible, malnourishment. So there's other factors, in terms of that. And those kids, again, it's going to be more along the lines of, behavioral difficulties, executive difficulties that we will see with extreme maternal stress. We could see some other cognitive impact, but that's going to be more secondary, likely. The thinking is it's a more secondary, the other factors that are causing that increased stress, such as, decreased nourishment or decreased kind of safety factors. So if you're thinking about kind of those early ACEs. In terms of breastfeeding, this is really helpful in terms of kind of building those social connections, and bonding, as well as kind of helping with early language and development. So at birth, babies can only see about a foot, which is the distance from kind of mom's breast to the face. And so I just said that on live TV. And so if you think about that, right, in those early days, putting a kiddo in a bassinet and kind of propping a bottle up is, so that's kind of the extreme. They're not going to have that same influence, but, so this is really why we are huge proponents of, even skin to skin. So even if you're not breastfeeding, there's really good benefits of skin to skin and skin to skin with dad. So shout out to dads, since you guys asked about father's influences. So, all of that's going to be really helpful. There's also, also, so skin to skin, not just with breastfeeding, helps with the regulation of body temperature and heart rate, and kind of mediating stressors. So there's a lot of other great, wonderful things with breastfeeding, but that would be like a whole nother talk. But those are some quick ones.
So we did have a lot more questions that came through, but I want to be mindful of our time. So thank you so much for coming today and talking with us. If anyone did have any burning questions that they really want to try and get answered, you can definitely email us through our website, and we will try to get some answers for you. I also wanted to take one quick minute to give a shout out to our sponsors for this series for their financial support, including APA's Committee for Early Career Psychologists and the American Psychological Association of Graduate Students, as well as APSIN, the Association of Postdoctoral Programs in Clinical Neuropsychology, the International Neuropsychological Society, and the Society for Clinical Neuropsychology, or APA's Division 40. So thank you so much, Dr. Bordas-Edgar, for being here today. I know this was a really wonderful presentation for all of us, and look out for the recording online in the next few days.
Great. Thank you so much. Appreciate it.
Thanks.